lineup of distinguished We have a great lineup of distinguished speakers today who will be speaking on updates in clinical management of obesity. Before we begin, I would like to remind all participants to please stay tuned to the end of the webinar for the attendance link and also your e-certificate. To all local medical doctors, please scan the QR code shown on the screen using your CPD app on your phone. The webinar is open to the public, and we hope all of you will gain new knowledge from today's webinar session. To all viewers from Zoom and also Facebook, please feel free to ask our panel questions by typing them in the comment section. The Secretariat will forward them to our moderator. Once again, we want to say thank you for joining us for our third and also final webinar series of Obesity Week Malaysia 2022. Please join me in welcoming Dr. Feisul, Idzwan Mustafa, the Deputy Director of Non-Communicable Diseases of the Disease Control Division, Ministry of Health Malaysia. Dr. Feisul, the floor is yours.
Thank you very much, Jasmine. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Salam sejahtera, ladies and gentlemen. Firstly, I'd like to thank Maso for inviting me to chair this session. Obesity Week Malaysia 2022 is a collaborative effort by the Malaysian Association for the Study on Obesity, which is MASO, and the Nutrition Division, Ministry of Health Malaysia. This is held in conjunction with World Obesity Day, which takes place on the 4th of March every year. Among the objectives of this event is to increase the awareness and encourage advocacy, improve policies, and share experiences about obesity. So this one-week program comprised of a physical event, which was successfully held at Sunway Velocity Mall Cheras, social media contests, as well as online events, which is the webinar series. So this webinar itself is the third of its webinar series. And today, this webinar will focus on the clinical management of obesity. So for these next 2 hours, from 2 to 4, we will have 4 renowned speakers with us today. So just to explain the format, each speaker will be given a total of 30 minutes. So we hope they can stick to 20 minutes of the presentation and 10 minutes of Q&A. So we're going to have the Q&A immediately after each presentation, because each is slightly different in its scope, lecture in its scope. So we're going to have 20 minutes presentation and then 10 minutes Q&A immediately after. So we're going to have that. So I'm just going to start off with, we're going to have a slight change in the order of speakers. So first speaker that we will have this afternoon, if I just make the introduction, Professor Dr. Norlaila Mustafa is a senior consultant physician and endocrinologist with 20 years of experience working and now at Hospital Chancellor Tuanku Mukris in Cheras. A clinician and a researcher. She is currently the Deputy Dean for Postgraduate Faculty of Medicine in UKM. She is active in several professional organizations at international and national levels, and her research interests includes type 2 diabetes, obesity, diabetes in pregnancy, and reproductive medicine. So today, we will hear her speak, and the title of her presentation is Progress in Pharmacotherapy for Obesity. So I'll pass the floor to you, Laila.
Right. Thank you very much, Dr. Feisul. You can see that, we share the same father's name, but we are not siblings, yeah? Right, I've known Dr. Feisul for many years already. And I would like to thank MASO and also Malaysian, the Nutrition Division of MOH for inviting me to participate in Malaysian, in the Obesity Week in conjunction with World Obesity Day, or March is considered as Obesity Month. So let me share my slide. Okay, right. I hope you can see my slides here. Right, so the title of my lecture today is Progress in Pharmacotherapy for Obesity. Right, so I hope at the end of this 20-minute talk, we all should be able to learn a bit about, why there's still problems with obesity, the unmet needs for patients with obesity. We listen to the unmet needs for diabetes. Obesity is basically the same. Individualizing management of obesity, similar to any other disease, we should individualize our management. At the end of the day, I hope we'll be able to understand the safety and efficacy of pharmacologic options for the management of obesity, and what are the emerging treatment with regards to anti-obesity management. So impact of obesity epidemic. Now people are busy talking about COVID, pandemic, now endemic. So obesity has been an epidemic. If you look at this data, our own Malaysian data, you can see the green line represent overweight patients or overweight subject based on NHMS data and few other studies like 2007, the Malaysian Metabolic Syndrome study. So it represents quite a big population in Malaysia. So you can see the prevalence of both overweight and obesity, which is the red line, has been increasing over the years. Okay, and I can anticipate with MCO and COVID-19, we've been working from home, staying at home. I can predict that in 2 years' time, when we have our National Health Morbidity Survey data, the graph will keep on increasing. And if you look at this is just to share with you the regulation of body weight. It's a bit complicated, and that's the reason why managing obesity is not simple, straightforward of you don't eat and that's it. So the brain basically controls both hunger and systemic energy metabolism, and it harbors most gene products and pathways that have been linked to obesity in genetic studies. And this then provide a roadmap for more informed anti-obesity medications development. So, and if you look at this, the next slide that I'm going to share with you. Oops. Okay, it's actually complex, how actually food is intake is being regulated. So if you look at central nervous system, is actually a homeostatic system whereby the hunger and satiety is being controlled. But at the same time, there's also a reward system in which it overrides to produce food intake even in the absence of hunger. That's why sometimes you see, why, someone, she or he has been eating and yet can even take, another plate of food. And this central regulation of energy expenditure is really complicated. There's a lot of other hormones and signals are also involved. Peripheral signals that involve leptin from fat is a hormone, GLP-1, GIP, PYY, OXM from small intestine, you can see here, and pancreatic polypeptide, amylin, insulin from pancreas, and also ghrelin or the hunger hormone from stomach. So at the end of the day, that will then lead to whether the patient will eat more or eat less. And when we try to lose weight, somehow or other, our body tend to resist. And this happened across adulthood whereby all individuals will tend to gain weight. And in this obesogenic environment that we're living in, it doesn't help either. So when someone tries to lose a few kgs, example, so body will act physiologically, for example, the appetite will increase, satiety will reduce, and the metabolism will reduce. And along the way, as along the way across adulthood, people will gain a weight, then they develop, goes into the new normal weight, and they try to lose weight again, and the body will react again. And, eventually the weight keep on increasing, across adulthood, and, and at one point, they cannot actually control, and they just keep on putting on weight. And the other thing about weight loss is there is also appetite adaptation. So when there is, someone try to lose weight or has lose weight, there's increase in ghrelin or hunger hormone, and that will then lead to suppression with a meal. So by right, when you already lose weight, the hunger hormone should actually reduce, but unfortunately, there's increase in hunger hormone, and at the same time, the hunger hormone is not suppressed as you take your meal. And similarly, there's a decrease in satiety hormones like PYY, cholecystokinin, GLP-1, amylin. And even though after a meal, it doesn't actually increase, so only slightly increase rather than, keep on increasing after a meal. By right, the satiety hormone should increase after you have a meal. So this is the appetite adaptation to weight loss, and that is the reason why the weight loss is not as simple as what we expected. And apart from appetite adaptation, there's also a weight reduction. The weight reduction, as the body weight decrease, the energy expenditure also decrease, and this then lead to a new steady state with lower energy intake is being established. And how much does this actually happen? So it's actually corresponding to how much the weight has been lost, and also how much the efficiency is actually increased. For example, if someone lost about 10% of their weight, there'll be maybe about 15% decrease in energy expenditure. And then to maintain this steady state, the energy intake must also decrease by 15%. So this adaptation may be due to leptin. Leptin is being secreted by the fat cells. So as you lose weight, this is what happened. And with that, metabolic rate also play a role. So metabolic rate before and after weight loss will also depends on how much someone has lost weight. So this just to give you an idea why losing weight is not as easy. So goes back to my main topic today, the anti-obesity medication. The pursuit of anti-obesity medication or AOM, anti-obesity medications, AOM, has been challenging throughout the years. There's a lot of failures with anti-obesity medication, even though after reviews, after we got the regulatory approval, for example, sibutramine, fenfluramine, dexfenfluramine, and rainbow pills, all because of adverse cardiovascular effects. And rimonabant was supposed to be the drug in the early 20s, but because of the increased suicidal risk, it was again terminated, or it was stopped. And the other problem with anti-obesity medications are likelihood of drug dependence, like phentermine and fipramone, and also catin hydrochloride. So there's a lot of anti-obesity drugs or medication being developed throughout the years, but there's a lot of issues. And even though after the approval being given, the drugs has to be stopped or terminated. So what are the anti-obesity drugs that can be used at the moment for long-term use? So what I'm going to share with you, we have Orlistat. It was approved in 1999 for adult use. In 2003, it was approved to be given to adolescents more than 12 years old. This drug should be given 3 times a day together with multivitamin. It acts by It is actually a gastrointestinal lipase inhibitor, and the weight change as compared to placebo is about 2.5 kg maximum. But again, depends on how good someone or that particular person control their diet and do exercise as well. But of course, this drug is not very famous among the patients because of the side effects that they face. And in 2012, phentermine plus topiramate has been approved for the use of adult only, is given once daily. How does it work? It is actually a noradrenergic and GABA receptor activator, kyanide and AMPA glutamate receptor inhibitor. The weight change up to a maximum of weight loss of about 9 kg. So it's pretty expensive. But again, this is control item, and you have to observe the side effects like palpitation and so on. And in 2014, 2 years later, naltrexone and combination bupropion ER was approved again for the use of adult only. Both phentermine plus topiramate and naltrexone plus bupropion not available in Malaysia, but we have phentermine. Topiramate is basically is a psychiatric drug. So for naltrexone and bupropion mechanism, this is an opioid receptor antagonist and dopamine norepinephrine uptake inhibitor. The weight change over 1 year compared to placebo about 5 kg. So the next one is liraglutide, was approved in 2014, same year as naltrexone and bupropion, and 6 years later, in 2020, was approved for adolescent. And liraglutide is available in Malaysia. This is the GLP-1 receptor analog. It's a daily injection, and weight change over 1 year compared to placebo about 5 kg. And the new one, the new kids on the block is semaglutide. Sorry, was approved last year. Is given weekly. Again, this is a long-acting GLP-1 receptor analog, both liraglutide and semaglutide by Novo Nordisk. And 1 year weight change with semaglutide is about 12 kg maximum. Right, so if you look at this graph, comparing the weight loss medication for appetite regulation, you can see with different studies, phentermine, topiramate, naltrexone, bupropion, liraglutide, semaglutide, you can see that semaglutide actually give the highest response with regard to weight loss at 1 year. And again, just want to share with you, 5% weight loss if the person with obesity or the patient will actually do an intensive lifestyle intervention, and adding another medication like what I mentioned earlier, like naltrexone, phentermine, Xenical or Orlistat, will increase the percentage of weight loss to about 10%. Semaglutide give a better weight loss reduction, about 15%, and of course surgery like Roux-en-Y, gastric binding and sleeve gastrectomy will give almost 30% weight loss response. And why there are challenges or in terms of anti-obesity medications development. The first one is because obesity is caused by, obesity, there is heterogeneity of patients cohort. Obesity is a heterogeneous condition. It's rare monogenic, and also more commonly polygenic. So most common is polygenic, but of course there's a monogenic cause of obesity, and it's associated with neurobehavioral, endocrine and metabolic causes. Not straightforward, there's many other factors that lead to obesity. Obesity related factors and also quantitative loci are found on nearly every chromosome. So development of drugs is very challenging. So heterogeneity in genetic, epigenetic and environmental risk factors is of major importance, and therefore it will also affect the individual response to certain pharmacotherapies. Second is translation of pharmacology from animal to human. we know weight loss really translate from rodents in study to human, but the maximal efficacy is basically lower in humans as compared to rodents. So, you know, studies doesn't actually translate to real life data. And although like this compound, anti-obesity, whether it improved body weight, lipid and glycemia in rodent and non-rodent human primates, but not in human. So there's also a problem, a challenge that the pharmaceutical or researchers face. The other one is neuroendocrine consideration. Of course, the reason why I shared with you a few slides about, you know, why there's hormones, the regulation with regards to food intake, satiety and hunger. So there's a peripherally derived endocrine factors that regulate food intake, but also there's neurocircuits in the hypothalamus and other brain regions. So that's another challenge that, you know, a lot of us that don't know yet. And of course, the safety effects. So initial priority, of course, to safely achieve maximum weight reduction, sustained therapy and lifestyle changes. But there's insufficient cardiovascular safety safety data in clinical trials, and lack of preclinical models that reliably predict human cardiovascular safety optimal outcome. So that was the reason, and were the reason why in the past there are many anti-obesity medication being pulled out from the market because of the safety problem. And having said that, we also have imaging treatments for obesity. What I want to share with you just quickly is tirzepatide. Okay, it gives a slightly more percentage or more weight reduction as compared to semaglutide, and the other one is cagrilintide with combination of semaglutide. If you look at this slide here, the weight loss almost, you know, reaching towards bariatric surgery. So tirzepatide is a dual glucose-dependent insulinotropic polypeptide and glucagon-like peptide GLP-1 receptor agonist. So it has both GIP-1 and GLP-1 receptor. So in a phase 3 clinical trial, tirzepatide, which was produced by Eli Lilly, have shown to reduce body weight more than 15% in about 27% of patients in that study. So this was a phase 3 clinical trial. And the other one is cotadutide. Cotadutide basically being developed by AstraZeneca. This is a co-therapy GLP-1 receptor analog with glucagon agonist. Okay, and this phase 2b study showed there's a reduction in weight and also hepatic fat content. So this formulation is being developed basically to treat NASH or a non-alcoholic non-alcoholic steatohepatitis or liver fatty liver in metabolic syndrome patients. So you can see these are the mechanism, and 15.5% achieve weight loss greater than 10% with cotadutide. And cagrilintide is a long-acting amylin analog. It's a weekly injection developed by Novo Nordisk. Phase 2 clinical trials have shown about 10.8 reduction with the highest dose, which translate into 11.5 kg of weight loss in population studied, which was about, I think, 300 over subject in the UK and in the US. So this is another promising data. So what else in the development with regards to weight loss drugs or anti-obesity medication? So I can share with you GLP-1, cotadutide I've mentioned earlier. This is a dual agonist, GLP-1 and GIP by AZ or AstraZeneca. Of course, there are other companies who come up with other agent or other formulation as well. And GIP, GLP-1 dual agonist, another one. A lot of companies are moving towards GLP-1 as anti-obesity, and it goes on. Is all incretin hormones, glucagon analog. I've mentioned about glucagon just now with glucose, and leptin sensitizer. Leptin basically for leptin resistance patient is also being developed. I'm not going to go into detail. Of course, amylin analog, cagrilintide, as I mentioned earlier, but there are other appetite suppressants that's still being developed in phase 1, and drug that targeting the ghrelin pathway or the hunger hormone, try to suppress this ghrelin production. So a lot of development are there with regards to anti-obesity medication. But what's available, I can tell you, is people are concentrating on the gut hormones to lose weight. So just quickly to conclude, pharmacological management of obesity has a lengthy history. Of course, there's many drugs has been pulled out, and left with 5 that I can share with you at the moment that's been approved by FDA, and then 3 of it available in Malaysia. Phentermine is available, but not the combination with topiramate. Multiple failure with anti-obesity drugs is basically due to safety reason, whether it's cardiovascular safety or patient try to commit suicide because of depression. Long-term and large-scale clinical trials in heterogeneous patients are needed when we talk about anti-obesity medication. And I can say for now, most promising anti-obesity are dual therapy co-agonists of gut hormones, GLP-1, glucagon, amylin, and gastric inhibitory peptide, or GIP. And with that, I thank you. I think I finished within 20 minutes here, Dr. Feisul.
Thank you, Prof. Norlaila, for giving us that very fast yet comprehensive overview of what's available right now, what have been used before, and what is coming up. So we got a question already from Hadi Rushaimi from MSU Shah Alam. The question is, which has more side effects and has better effects on controlling obesity, by using drugs or by consuming natural remedies or food? I think just to simplify the question, perhaps you would, maybe I would reword the question perhaps. So what kind of patients do you think best to use drugs, and what kind of patients in your experience would be best to try non-pharmacological? If there are any specific guidance you can provide to the listeners, to the viewers today.
Yeah, well, there's no specific guidance, but of course when they start developing complication, and we know the reason why they put on weight is because the food intake and the lack of activities, right? And the medication is on top of it. I always start with most of the time people do put on weight because of the intake, the food intake. Is actually excessive. So I will ask them to cut down that first, and if they're done, they show that their commitment, then I will add on the anti-obesity to help reduce the weight further, so that they feel lighter and they will become more keen to do exercise, because these anti-obesity are expensive. And when you talk about Olistat, there's a lot of side effects, flatulence and so on, which people don't like it, and 3 times a day. And when you talk about phentermine, a lot of people complain of headache, palpitation, and it can cause high blood pressure in some patients. And you have to monitor, and you don't actually give for a long term. You give for maybe about 3 months, and then you stop, and then you give again. So just to suppress the appetite, so they lose weight, and then they become really motivated to do exercise and maintain the healthy lifestyle. Of course, the other 2 not available, so I'm not going to talk about it. I haven't even tried myself. The other two injectable are Saxenda or liraglutide with daily injection, and semaglutide, which is a weekly injection, but it's very expensive. So you can only give for short duration, because most of the patient after some time they say, doctor, it's very expensive, I cannot, sustain. But again, this is a short term with regards to reducing the weight, so that patient will become more motivated. Of course, with GLP-1, they have a good cardiovascular outcome data, so I'm not worried about continue on. With regards to side effects, they have a bit of GI side effects like nausea, vomiting, but for a few weeks, but after that the side effects sort of wear off, so that's okay to continue. The only problem is the cost with that. And again, having said, even being a doctor, I still recommended a healthy lifestyle. Whatever medication that you take, you have to control your diet and do exercise regularly. And it's also good for for your general well-being with regards to exercise.
Right, thank you. Another question via Facebook, a very specific question. What is the difference between semaglutide and liraglutide?
Right. Semaglutide is long-acting GLP-1 analog developed by Novo Nordisk. Liraglutide is GLP-1 analog developed by Novo Nordisk as well. But liraglutide is daily injection. So it's a shorter duration. That's why you have to give it daily. But semaglutide, since it's longer acting, and the difference is in the peptide or in the amino acid. So that's why the action is longer. That's all. In terms of side effects, they share the same side effects, nausea for the first couple of weeks and so on. That's the only difference. And of course, price will be slightly.
Yes, the price.
Yes.
So question from myself, Prof. Laila. So
Yep.
what would you say the most commonly encountered questions that you get from the patients that you see when it regards to them starting pharmacotherapy for obesity?
Right. Well, it's a bit surprising, because when they come to see you, they expect miracle to happen, meaning they expect you to give them medication. As compared to diabetes patient, doctor, can I control my diet or not? But obesity patient, they will never ask that. They will say, tak ada ubat, doctor. Because they want to lose weight, you see, maybe more for cosmetic reason, more for mechanical reason, because of back pain, knee pain, and so on. So they're not very apprehensive in terms of taking medication. But the only issue with regards to GLP-1 is the price. So no problem with that, but I tell them drugs is not the only way. You have to do other things at the same time, like lifestyle and also diet, because most study with example with liraglutide, right? Without intensive lifestyle intervention, the weight reduction is not as tremendous, or it's not as impressive as liraglutide alone, and we know that.
No, that's a very interesting perspective. I've never really thought about it. Yeah, you're right. Diabetes patients do not want to be on meds.
Yes.
And yet you have obesity patients who want to be on meds despite knowing the various side effects. So all right. I see Prof. Ismail raising his hand. Prof.
Hi,
Hi, Prof.
Hello. Well, your earlier slide, the history of drugs available for obesity management. I think you missed out sibutramine.
Yes, sibutramine, it was there, the cardiovascular.
Yeah, but it should be there. It was in the market for some time before it was pulled up.
True.
Now, my question is more ethics related. Yeah, the prevalence of childhood and adolescent obesity is increasing. I don't know if what is the current practice in Malaysia now. If there is any drugs advised for adolescents in the current practice to reduce excessive weight, basically.
Right. Thank you, Prof. At the moment, what's the drugs that has been approved is only Orlistat.
Orlistat, yeah.
Yeah, even in Malaysia, liraglutide, I don't think this year actually approved for adolescent yet, because it's non-formulary, meaning patient has to buy, and for JPA or government patient they can claim. So I myself never prescribed liraglutide for anybody below 18, but Orlistat, yes. But again, the kids doesn't like it. They're 16-year-old, 15-year-old, because of they tend to pass motion and the fat content.
Yeah.
And I still believe in the diet, exercise for the kids, because they
That's
don't
not
have
good for the
limitation.
pharmacist. That's not good for the drug company if you believe in that. But anyway, so what do you know how much the government spend on anti-obesity drugs at the moment that goes to the clinic to prescribe to patients? Do you know?
Well, what I know, maybe Dr. Feisul can add, for a phentermine that is being approved is a control drug. Even GP, only certain GP, and I'm not sure whether clinic kesihatan can prescribe. I don't think so. So only certain centers with obesity clinic can actually prescribe. I'm sure my colleague in Putrajaya, she doesn't have access to phentermine even, although she has obesity clinic. So not many drugs available at the moment.
So thank you.
Okay,
Thanks,
I think we'll let Prof. Norlaila go. Thank you very much,
thank you,
Prof, for that sharing session. So we're going to move on to the next speaker. I would like to introduce Professor Dr. Firdaus Mukhtar, who's a consultant clinical psychologist currently working in University Putra, Malaysia. She is an active academic and active researcher with numerous publications. And the title of her presentation today, this afternoon, is Cognitive Behavior Therapy for Obesity. And with that, I pass the floor to you, Prof.
Thank you, Dr. Feisul Idzwan. Assalamualaikum and good afternoon, everyone. Before I start my presentation, I would like to share that at Hospital UPM, we have two clinics that helping patients with weight management. One is a metabolic and obesity clinic, and the other one is Putra WeFit, in which both are multidisciplinary team that consists of surgeon, endocrinologist, dietitian, ENT and rehab medicine specialist, family medicine specialist, and myself. I'm focusing more on psychological intervention, mainly cognitive behavior therapy. In 2016, my first publication on effectiveness of G-Slim program to reduce weight among adult sample was proven managed to achieve targeted weight loss, improve self-efficacy, and created a positive support system compared to control group who only receive individual diet counseling. Running a group-based approach really need more effort to deliver compared to individual session. And from this study also, we found that additional session on psychological component managed to achieve targeted weight loss, not just at post-intervention, but also sustained at follow-up stage. Therefore, it is evident that in local context in Malaysia, the G-Slim program is ready to be used and can be replicated in similar setting with possible enhancement for exercise self-efficacy, attendance, and adherence to self-monitoring. 2 years later, we were testing a reduced program. It's a family-based intervention using face-to-face and social media to reduce weight among children through their parents. Several psychological elements were added, such as goal setting, problem solving, self-efficacy, and relapse prevention to strengthen the parents to monitor their child's diet and exercise. And as we can see here, the reduction trend was consistent, faster for reduced program compared to the control group for whole sample, overweight, and obese sample, respectively. So what we have in the world literature, one of the established program for obesity is called CBT-OB, in which patients were treated in a daycare hospital or residential for the first 3 weeks to cover weight loss module, and phase 2 is to cover module for weight maintenance. In Malaysia, manpower is the issue, if we were to conduct similar program, but I believe it is not something impossible if you have multidisciplinary team. Right. So let's move on to why CBT in weight management. CBT itself has been documented as evidence-based for mental health intervention in many guidelines. So CBT in weight management in particular has been mentioned in SIGN guidelines, NICE, European Obesity Management Task Force, Bariatric Surgical Services in Scotland, and BPS report. So it is hoped that there will be more awareness and evidence-based too in Malaysia. So how CBT could help in weight management? Basically, CBT is a psychological approach that emphasizes on the role of thoughts in how we feel and how and what we do. And so it is a collaborative efforts between therapists and patient or parents for children with obesity to work on change plan using a structured educational framework to cater both emotional and behavioral problems that disturbing their weight loss journey. So generally, CBT strategies giving specific skills or strategies at preparation stage, action and maintenance phase, and also to avoid yo-yo diet back to old lifestyles or what we call relapse. So let's see this triangle as an example. The situation or what is trigger this person after coming back from home in the evening and have some thoughts like, I had a stressful day, I deserve a takeaway. Or I have been good all week, now I deserve, and the image of pizza, cakes, or any sinful foods that usually carbohydrates, and started to be disappointed, angry, annoyed, until it's actually affecting their action or their behavior to straight away pick up the phone and order takeaway and reach for food and drink without planning ahead to relieve the feelings or emotion. So not just that, someone might not aware or started binge from thoughts, but it was triggered by the external factors, such as having too much food at home, too much social eating occasion, or internal factors such as feeling anxious, tired, or stressed that influence their problematic thoughts and unhealthy eating behavior. And what makes the cycle worse when they enjoy positive consequence afterwards, like I feel good after eating ice cream, or I enjoy eating with others and whatnot. All right, so let's move to what are those skills or strategies that we teach in CBT component. Basically, different manual have different ingredient, but for CBT, the ultimate goal is actually the same. By improving our thinking styles, it will affect our emotion and behavior to have a healthy lifestyle one. So among the component or skills to be taught are like goal setting, self-monitoring, problem solving, stimulus control, stress management, cognitive restructuring, social support, and relapse prevention. So all these are not structured after one another, but we customize it according to the patient's need. But most important is to start with SMART, specific, measurable, achievable, realistic, according to timeline of goal setting. So their change plan should consist of what is their goal in a day, in a week, in a month, followed with what is actually the most important reason they want to make these changes. Okay, how they reward themselves, what are those obstacles, how they cope with the difficulties, and summarize it by putting it together and finish it by checking if that is really what they plan to do to lose weight. So take this as an example of how thoughts play a role in making weight loss difficult. I used to tell myself I was really fat and ugly. My body image has gotten so bad that I rarely go out. When I do go out, I often think people are staring at me and making comments about my weight. I spend hours deciding on what to wear, and sometimes I get so frustrated that I decide to stay at home and eat instead. So the skill to be given here is for patients to counter back the evidence and advantage of their thoughts in losing weight. One of the skills that is important here is called cognitive distortion. It is basically about categorizing the unhelpful thoughts among the most unhelpful one. When patients do not see the most unhelpful one of the thoughts, when patients do not see themselves as super obese, regardless what their BMI or their size telling them, such as making a joke that I'm not fat, I'm just easy to kidnap. That's advantage of the fat people, they're not easy to be kidnapped, that kind of thing. Or the other type of person is the one who do not realize their weight is alarming and keep blaming the external factors that make them fat, such as this picture. Finally, COVID-19 is gone. Now, how do we go out? You see, right? So these are among the worksheet that we will guide patients. The left one is on goal setting, and the right one is to record their dysfunctional thoughts that lead to unhealthy eating behavior or sedentary lifestyles. Now, let's understand further on how we help the emotional dysregulation. Every time I visit my mother, she always buy lots of cakes and biscuits for me coming. I keep telling her that I'm trying to lose weight and that I don't want those foods anymore. She always says that I'm fine the way that I am and don't need to lose weight. Most of the time, I end up eating the cakes and biscuit because she always seems really offended and put out when I say no. But the other day, I got really mad and shouted at her. She got very upset and started to cry. It doesn't matter what I do, I can't get the message across that I don't want to eat like that anymore. So sometimes it is not just the self-emotion, but it's also could affect it from others' emotion. So this is where we give the skills on managing their emotion effectively so that they can cope better with the difficult situation. So the most popular emotion skills to teach is mindful eating, so that patient can utilize all their senses when they eat and they are conscious or aware of attitude towards eating behavior. The other challenges that is common raised among patients is on how to manage craving or the urge to eat. So basically, we will teach on how to distinguish between psychological desire to eat and a real physical hunger. And we provide them some distraction techniques that may be activity-based or cognitive-based. So let's take this as an example. When somebody is craving for chocolate, they started to try to eat fruits, and then the craving still there. They try nuts, they start yogurt, but the craving still there. They try to eat low-carb protein bar, no, they are still the same, and they start to binge on chocolate and feel guilty. Okay, whereas for if you understand the craving management, you really think that you want to eat chocolate. Yes, you eat chocolate, little bit, and move on and enjoy the rest of the day. And then you are relaxed knowing that your blood sugar is okay or manageable. And the last component in CBT is behavior. Let's see this example. Someone wake up late, so she is late for work, had to miss breakfast, then overeat during lunch. And when she get home, she feels stressed and tired, goes straight into the kitchen and feel very hungry and can't be bothered cooking. So she called takeaway, and while waiting, she eat junk food, keropok, kerepek, that available. And again, she overeat in the evening and feel tired again to exercise. So basically, changing behavior on what we do, is important when we are aware what we do to lose or to gain weight. So in terms of behavior, we divide into two factors that influence our behavior. One is external factor, such as food environment, advertisement, events, and whatnot. And the other one is internal factors that affected our behavior, such as impulsivity, instant gratification, couldn't differentiate full and hunger, strict diet, and so on. So one behavior strategy is we will have patients to design their lifestyle to limit exposure to problem situation and foods. So we guide on how to do a food storage, food preparation, how to reward positive eating behavior, and giving them skill to learn self-control. Towards the end of CBT session, we will cover relapse prevention, weight maintenance skills, and in order to understand how to stop weight cycling problems. So basically, compared to those who are just focusing on dieting to lose weight, result will be fluctuated or even having more complexity, such as binge eating disorder, decreased metabolism, and slowing down the rate of weight loss with each attempt with mortality risk, compared to those who learn skills to manage their thoughts, their feeling, and action to manage their weight problem. So take-home message from today's presentation: pharmacotherapy, diet, surgery, and exercise are not magic to lose weight, and all this incomplete without psychological first aid. Psychological intervention is not merely about motivation, but it covers lifestyle skills to enjoy weight loss journey before, during, after, and at maintenance phase of weight management. some of the reference for today. With that, thank you for listening.
Right, thank you, Prof, for that overview. For me personally, I feel the psychological aspect when it comes to this eating behavior is something that we do not give enough emphasis. We still feel it's lack of awareness and lack of knowledge, right? There's sometimes there are these behavioral drivers that's causing this unhealthy eating, malnutrition, whichever way, either overeating or not eating. So while waiting for questions, just stand to be guided by the Secretariat. So maybe I'll start off first, Prof. So what would you say some of the misconceptions that you get from healthcare workers first when it comes to the work that you do and weight management?
Okay, good at the Feisul. Okay, good question. From the healthcare providers first, yeah, so it's not patient, right? That psychologist is not needed. Okay, psychological intervention is easy. Everyone can do it. All right. Okay. So lots of people think, not just for the professionals or the patient, think that the psychological component is easy because they usually relate it as everything is on your own. Okay, so your own motivation, your own inner spirit, your own inner thought. Okay, so regardless how good is a person or how best is the psychologist to give the consultation, if you don't want to change, you don't change. Okay, so that's why it just like defeat the purpose of having the consultant in the management, because at the end it's all back to the patients or the individual and stuff. Okay, so I think this is something that we really need to improve. Okay, because the specialty is the specialty of the psychological intervention is not something that is just exists or emerge out of blue, right? If you look at the lots of management in a medical aspect, okay, so where the need of psychological aspect is needed or embedded in every aspect of medical condition, and so be to obesity as well. We are treating obesity as a medical condition, so there is a psychological aspect, not just after having or being obese, but is actually before the leading towards obesity. Okay, so that is where the lifestyle, how their emotional management before, say 10 to 15 years before, okay, sometimes it could actually contribute to their lifestyle in terms of food intake and also physical activity or exercise. Okay, so I believe that not just beating what the theme of the conference, beat the obesity, but beat also the misconception perceptions of psychological intervention in our weight management.
All right, man, I have a follow-up question, but before that, I see Prof Ismail's hands up. Prof.
Oh, itu tak turun pada tadi punya. Sorry. Yeah, you gave us an account of several programs that can psychologists use to help people with weight problem. What I'm trying to get from you is, from your experience, if you have already introduced this program, is there success stories? What's the results after all this intervention? Do you find a positive side of it? Oh, I'm not too sure. I mean, I'm sure you have used this CBT op ni kat Malaysia kan dengan patient you.
Yes.
And I would say how many patients you have, how many really actually follow or have problems, if they have, what they are, and things like that. Maybe you can elaborate a bit.
Okay. Thank you, Prof. Okay, we have started our clinic metabolic and obesity in UPM, and also the Putra We Fit, the one I mentioned earlier. Okay, so this is a multidisciplinary team that look at the weight issues among patients. So basically, we do the screening, comprehensive screening that comprises of the medical assessment, ENT assessment for sleep study, of that, and also include mental health screening. So from there, they will screen those who are, because I'm using this Saringan Status Kesehatan Mental, the screening for mental health, basic mental health. So if the scores above 14, so that is where they have to go through my session. Okay, so regardless whether they are aware or not the need of psychological issues there, so they have to go through my session in order to see what is actually the issues related to emotion, thoughts, and behavior that related to their weight issues. That's number one. Second, there are patients actually not getting the score above 14 where they are not actually seeing me. But the endocrinologist, the surgeon, the dietitian see that they are problematic patients. They've taken Saxenda, they have done the bariatric surgery, they have gone through the meal replacement, but then their weight not change. Okay, so usually this second type of patient usually will have to go through me, even though their mental health screening not telling them that they're having any psychological issues. Okay, so what I will see from this type of patient, that is where I will try to understand what is actually the goals. Okay, what is actually the target that they want. Okay, and how honest that they are actually about telling the diary, about telling their food intake, their behavior, or that their lifestyle and whatnot. Okay, in the session, which is sometimes they are not actually telling the medical doctors or the dietitian. All right. And the third one, of course, by having the mental health issues, be it depression, bipolar, and OCD, and sometimes they have difficulties to actually to control their thoughts or their compulsion. Okay, so that's why it leads to the weight issues. Okay, so this is sometimes it will combine with the psychiatric clinic as well, with medication, or combine with just CBT or CBT with a psychiatric medication. Okay, so about the successful of my treatment, the one that I mentioned, the two studies that I have published was mainly focusing on the behavior modification, because this is to start, because this study is actually happened 16 years ago. Because when I come back from Australia, I want to test whether this technique is actually easy approach for the Malaysians or not, because it really need a cognitive skills, okay, where you have to go through your thinking style in order for you to change your behavior. So this is not easy, because most Malaysians usually they just thinking of the emotion, they think of the symptom is much more important to change their problem rather than changing their thinking style. Okay, so that is where in individual session, when I introduced CBT, when we had the patient support, and we had the event for this week for the obesity awareness, most patients will say that after all, it's all come back to you, the willpower that you have, and how much that people influence, how good is the medication, is all about your own ways to actually to say no to certain food, and then push yourself to actually to be active compared to the previous lifestyle. Thank you, Prof.
Thank you, Prof. Actually, you have answered, Prof. Firdaus, you have answered another question on Facebook. Advice on managing snacking habits. It is about understanding the underlying drivers, right? I have to give the floor to the president of MASO, Prof. Gita. You have the floor.
Thank you, Dr. Feisul and Prof, for your very insightful talk. I have one question. Did you ever come across any patient, any obese patient that you have given this CBT or is there any possibility of them to have eating disorders after a long run? Do you have any data on that, on a paper to prove on this?
Okay, since we started the clinic about 1.5 years when our hospitals established. Okay, so at the moment we don't have the data yet. but we do actually collect the data as part of the screening, where as part of the assessment that we are actually doing, we do ask whether they have eating disorders or not. Yeah, eating disorder, it could be bulimia, anorexia, or binge eating disorders. Yeah, so this is something that we are aware. Okay, and then this is something that I will offer, either just concentrate focusing on their weight management at the clinic, metabolic and obesity, or refer them to the psychiatric clinic if they need more psychiatric and psychological management over there. Yeah, so it is the case are there, and we are aware of that. Okay, and then some of them are also not able or not eligible to actually to do bariatric surgery because of that reason. Yeah.
Oh, I see. So is this common among the youngsters, or do you see this in specific other age groups? Like?
Okay, so I'm seeing more adults than child adolescent. We do have child psychiatrists, Dr. Rahima, who are seeing the child adolescent cases. So sorry that I don't have any data for the child adolescent case. Yeah.
Okay, thank you.
But one thing that I want to say that when there is a child adolescent cases, I always get the parents in, so that it gave me more power and also control on how their behavior likes in the house, rather than just rely on the child or adolescent to actually to push them to lose weight. Yeah, thank you.
Thanks.
All right, Prof, one last question before I let you go. Another very specific question. Is the number of psychologists in our healthcare system adequate to support people living with obesity in primary care? Well, I'm laughing because you can just substitute psychologists for whichever category, right? So perhaps you can slightly elaborate on that in terms of roles, and what do you see we can use the specialty in a more efficient manner?
Right. Okay, thank you for the question. Yes, I think compared to the last 10 years, okay, so the number of clinical psychologists is not that much, but it's been significantly increasing nowadays. I think each hospital, main hospital or government hospital nowadays have at least one clinical psychologist, but to cater the whole hospital. For clinical psychologists to have this knowledge and skills for CBT for management, they need to have an extra training, okay, in order to understand on how to actually to handle the cases, because otherwise most clinical psychologists in our country, if they are local trained, okay, so this topic is very limited for them to actually to understand or to handle. Okay, so compared to when we were in overseas, okay, so this topic is quite thorough to be covered, okay, compared to the local clinical psychology. So I believe if they have the interest, okay, and also they must also make sure that the interest CBT work management, is it for adult or for child adolescent, okay, or even the youngest children, okay. So that is something that there will be different skills and also knowledge to cover in order for them to actually to apply at the clinical setting. So at the moment we are slowly try to develop them to have this regular training on this. I give a little training here and there for them to have to develop more interest in CBT for weight management. Yeah. So yeah, it is limited, but I believe that there is a growing interest among our clinical psychologists.
All right, thank you. All right, so we are still keeping to time, which I'm happy. So I'm going to let you go. Thank you very much, Prof, for sharing. I'm sure those of you who've got any follow-up additional questions can certainly reach out to you, right, to ask that even after the event. So we're going to switch gears slightly. I would like to introduce the next speaker, Dr. Nalini Selveindran, currently a pediatric endocrinologist at Hospital Putrajaya, and which is a major referral hospital for endocrine disorders in Malaysia. She's a member of various medical societies at international, regional, and national levels, and heavily involved in training and also research. Dr. Nalini's research interests are in the field of disorders of sex development and bone disorders. So she'll be speaking on the management of pediatrics obesity. You have about 20 minutes, Dr. Nalini, and then we will be following up with 10 minutes of Q&A. So with that, I'll pass the floor to you.
Okay, thank you very much for that very kind introduction, and I apologize to the organizers for messing up the arrangement a little bit just now. I would like to thank the organizers for giving this opportunity to talk about management of pediatric obesity. It's a topic close to our heart because sometimes when we think of obesity, it's difficult to persuade anyone actually that obesity is important in children. They just say the kids are cute, right? But of course, it is a big problem. You know, this is data from the WHO looking at different regions, and you look at our region, right? We have increased 50% from 2010 to 2016. This is prevalence really. And our own NHMS data shows us that, you know, that 1/3 of our children are overweight and obese, you know. If you look at the data of obesity from 2011 to 2019, it's increased significantly from 6.1% to 14.8%. And we did our own research, okay? So, you know, COVID came, and with COVID came lockdowns. And so we looked at our own type 1 and type 2 patients in our clinic and looking at the control and other things. But what we found was, right, pre and then post a lockdown, their BMI increased, the physical activity went down, and of course, they all had increased screen time, isn't it? But because they were at home and they didn't have much to do. So this is now a looming problem. So what I propose to do is not to give a very exhaustive talk on obesity, because I think there has been some overlap with the previous speakers. I will particularly look at what is different in pediatrics when you want to manage them, because the core management is the same. We use dietary, exercise, behavioral interventions, the drugs are coming the same, the surgical intervention. But what is unique to the pediatric population? I hope to shed some light on that. And of course, I would like to talk also on some barriers to management. Yeah. So how do you define obesity? And because children are growing, yeah, we need to use BMI charts, okay, and they change with age. And so depending on whether you use the CDC growth chart, so you have got overweight, which is more than 85th centile, and the obese, which is greater than the 95th centile. If you use the WHO growth charts, then you have other different ages 5 to 19, overweight is more than plus 1 SD, and obesity is more than 2 SD. And you have the ones for the younger age group, all right? And they have overweight more than 2 SD and obesity more than 3 SD. Now, how do you evaluate a child? And I'm just going to look at some red flags, okay? Because there's a lot of literature on, history and physical examination. Because as pediatricians, this is our armor, really, to investigate the child with our history and physical examination. When you evaluate, you need to look for pathological causes of obesity. It's not just because of energy mismatch, right? Diet and not enough exercise. Is there something else going on, organic? You need to assess very detailed the lifestyle and eating habits, because that's going to be a core, right? And how to manage this. And you need to look for presence of obesity-related comorbidities. And so this is a very extensive from Louis Barr's group in Sydney, on how to history take and examine. But I want to look particularly at red flags, because these are the things which should pop out, right? That you should be concerned, that you should get a tertiary center investigation. So if a child with obesity, all right, if you see this is the weight and it's going up nicely, but this is the height. And usually a child with energy excess will actually have a increased growth rate, all right? If that starts to plateau, that's a red flag, all right? Decreased linear growth or short stature, you need to rule out other endocrinopathies. And this is a child with actually Cushing's syndrome. Or if the obesity happens early in life, and of course, I do still see exogenous or primary obesity with a very young age group, but you always need to rule out genetic syndromes. And so we've got a child with Prader-Willi here, another child with POMC deficiency syndrome with red hair, right? Because they may come with genetic obesity and they also have other clinical features, right? And they sometimes have a very family history of severe obesity. So we will also assess the lifestyle and the eating habits, and particularly the sedentary behavior. So that means your screen time, how much time are you active, and also the sleep. And you look for presence of comorbidities. And this I just take from the Endocrine Society guidelines on when to screen for comorbidities. We usually start to screen at the age of 10 and above, or at puberty. But if there are significant symptoms of comorbidities, or you are worried excessive weight gain, we will screen earlier. And we screen obese children, and we screen overweight children if there are 2 or more risk factors, features suggestive of insulin resistance, or there's a very strong family history of very early onset type 2 or heart disease. There's history of GDM, or a small for gestational age or large for gestational age, or there are symptoms in that particular child. And we do blood sugars, cholesterol, liver function, urine microalbumin. And for other investigations, we look for what are the symptoms in an overnight sleep study or an ultrasound for PCOS, right? So by means, this is not exhaustive evaluation, but these are certain things which we will pick up and which are maybe peculiar in childhood. Now, coming to principles of management, I just want to highlight a couple of principles which are peculiar in childhood. Because childhood is a period of growth, okay? You are going to grow, yeah? Right? And thus, when you want to manage a child with obesity, you need to take into account the nutritional needs of the child, yeah? Thus, our targets are going to be more lax, maybe, because we take weight maintenance as an acceptable goal. Yeah. So for pre-pubertal, if you can maintain your weight or even have a slower weight gain so you can grow into the decline in BMI, that's fine. Okay. For pubertal children, we may be more aggressive, especially if they're post-pubertal. Then you can think of a gradual loss to maximum 0.5 to 1 kilo in a month. The other thing is childhood is a period of development. So when you say a child, basically you're talking about someone from infancy all the way to adolescence. And when we manage, we must tailor to that stage because you're not going to manage an adolescence the same as an infant. And thus, in infancy, you think of complementary feeding, breastfeeding, yeah? In toddlerhood, this is where you have the behaviors, right? You tell them you need to model healthy behavior. You don't go and snack unhealthily, right? You start having good sleep patterns, right? And then in childhood, that's when the family is important. You cannot manage a child in silo. You need a whole family together to manage, yeah? And so this is when you bring the parents together and do any intervention as a family, right? Because the parents will be important role models. Any of you who have kids know that the kid knows if you do it, they are definitely going to do it. You know? In older children and adolescents, this is when peers are the more important. Now, they won't want to come in with their family, their mom and dad. Yeah, they wouldn't like more usage of electronic devices or apps, you know, to record stuff. You know, they like that kind of thing. And sleep sometimes can be an issue in this group of children. So this is really the alma mater of how we are going to manage, yes? Management in, I suppose, even in adulthood also, but particularly more in childhood, is going to be very much heavy on lifestyle intervention, right? The dietary, physical exercise, behavioral intervention. So we focus on sleep and screen time. And because these children do have psychological issues in psychological intervention, but especially maybe in the ones who have got more comorbidities or who are more severely obese, this is when we think of pharmacotherapy and metabolic and bariatric surgery. So in these children, you assess, you use a developmentally appropriate management plan. You support long-term behavior. A lot of studies are talking about the fact that children, we don't plan for long-term weight maintenance programs, dietary changes, increasing their physical activity, screen time management, improve their sleep, and also strategies for maintaining their weight. And if necessary, you go on to pharmacotherapy and metabolic and bariatric surgery. So I'm just going to go briefly on some intervention. And this is really a review of Cochrane reviews by Louise Earls, really looking at 6 separate reviews. And this is basically, I'm trying to sell the case that lifestyle intervention works. Okay, so they divided these reviews into different ages, less than 6, 6 to 11, 12 to 17. And in all of them, there was some small reduction in body weight. However, as we all think of it anyway, anecdotally, that multi-component behavior change interventions are the most beneficial. Basically, you target different sort of behaviors. Yeah. And so with dietary interventions, the simple things we do, with the color coding of red, yellow, and green. Yeah, I particularly like this from this was from Louise Bohr's group in Westmeath, where she has a very extensive and a well developed unit really, where she is doing this very low energy diets in adolescents, especially for those who are with comorbidities. And especially to have a greater initial weight loss. And this is, of course, I don't have experience with this, but this is possibly something which may we need to think of. Sorry, yeah, it's not moving. And this is really and this I would like to show you would be a Cochrane review. A review. I'm going to it. Yeah, a systematic review, looking at different studies really, and the mean weight loss was actually 10.1 kilo with not much of details of the adverse event. So this is something which we may need to think about. Okay, how about exercise? And this is from WHO, where they think about, they suggest an average of 60 minutes per day. And so it's an average. So basically you pull the whole day, yeah, 60 minutes, but it's moderate to vigorous. Huh? It's not just light, but it's moderate to vigorous. And you start, so some physical activity is better. And of course, you use different things. You use play, you use games, even you walking to school, that's fine, yeah, all right. But what is important, which we can sometimes forget, is that at least 3 days a week, the child must have vigorous intensity aerobic activities, all right? That means something which is more vigorous, right? Like you're going to play a football game, all right? Or you're going to go swimming, all right? And even you need to have something also which strengthens the muscles and bones. So you jump or you skip, something in that respect, which this is to increase their cardiorespiratory fitness and also their muscular fitness. And so this is just examples of types of exercise where moderate is more walking, cycling, and vigorous when you actually play games. Screen time, this is the recommendation from WHO. You don't go more than 1 hour for 2 to 5 year olds and not more than 2 hours for 6 years old and older. And sleep, again, so we focus on sleep a lot because this is a great problem, especially with all this PDPR. Link between obesity and sleep deprivation is been well documented in the literature. I talk about behavioral management more because we use that in the sense that we need to have specific goals when we have these patients. We don't just give them, you do this, but you need to have a goal which you will re-evaluate when you see the patient again. So I tell them, you tell me exactly what you are going to do and we will re-evaluate it in our book. Yeah. So performance goals, like, what are you really going to do? Are you going to maintain your weight? Outcome goals. Are you going to monitor yourself? And stimulus control, and that's when you don't keep junk food or you don't keep your phone when you sleep, and those kind of things. And yes, our children do suffer from this. And if you ask children, they are being bullied. They do feel a low self-esteem. And so we are very careful in the language you use when you have a clinic, yeah, because it has to be non-judgmental and very empathetic. A lot of times families come in and then they complain about their children that they're not doing this. And this doesn't help because this is perpetuates the cycle, all right, which continues on this the behavior change, lack of behavior changes. And so this is really in our CPG, hopefully in our obesity, a CPG which should come out soon, really to look at the stepwise management. So after you assess, you measure and you counsel, and then you look at different stages. So where in the primary care setting, you start with changing behavior. And then in the next stage, you continue on with diet and physical dietetics referral. And then at the stage 3 is when you think of whether you want to need a pharmacotherapy or bariatric surgery. So I'm just going to touch very briefly on this because I do not have much experience with this, right? Really to say that this is what everyone is talking about now, liraglutide, okay? And it's really the paper by Aaron Kelly in the New England Journal of Medicine, where it was comparison between 56 weeks comparison between the liraglutide group and the placebo group. And they were using as increased dose up to subcutaneous liraglutide 3 milligram daily. And so they demonstrated that after 56 weeks, the participants in the liraglutide group had a greater decline in their, the more of them basically were greater decline in their 5% reduction of the BMI. That was 43.3% in the liraglutide group, as opposed to only 18% plus in the placebo group. And more of them had declined the 10% loss of BMI as compared to the placebo group. All right. And of course, we don't have this yet. There's not much other medication available. I don't have much experience with Olistat, but there's a very high attrition rate because of the side effects, if you can imagine. Metformin, we use it for our pre-diabetics and diabetics, but not for just pure weight loss per se. And so in children, we don't really know what are the rates, regain rates after you stop treatment or you carry on treatment. We don't know. We know the adherence is very low because a lot of parents say, why are you giving this for weight loss? We don't have long-term data, maybe on growth and development. And our children below 12 is another group which we have not very well studied on what to do with pharmacotherapy. The future looks like other forms of the GLP-1 receptor agonist, the semaglutide, which is a weekly one, the oral ones, yeah, which we are in the pipeline. I do put bariatric surgery here because I think that it does have a role for the patients who have a severe obesity, and especially for comorbidity management, really. And so I put up a teen lab study here, and this is a study which is well quoted, really. A prospective enrollment of 242 adolescents around over 5 US centers. And really, this was data after 3 years, yeah, of surgery, okay, where they demonstrated that the weight change was still there. And of course, the comorbidities, so you're thinking of dyslipidemia, that decline was still there. And there was a 95% remission of type 2 DM also after these 3 years, yeah. So there is a role, I don't have much experience again, but there is a role in patients who are possibly severe and who have got comorbidities. But really, what we really face in clinic, and I think which you will all face, is the barriers to our management. And this is a study in, I think, Mexico, really, looking at the high attrition rate in our obesity clinic, which anecdotally, real world data does show that, right? It showed that 43.7% dropped out before the third visit, okay? And only 1/3 asked to stop, so 2/3 just didn't bother coming after that, you know? And most of them dropped out after the blood tests were normal, then they stopped coming anymore for follow-up, right? And why did they say that? Because they said, I'm not fat, my kid's not fat, misperception of weight status. Number two, I don't have a disease. Why do I have to come to the hospital? Why do I need to come to a clinic? Because it's not a problem. And these were usually families who were, everyone was obese. So if they said everyone in our family is big, which he'll grow out of it, you know? And of course, the other important thing was socioeconomic factors, you know, I'm working, I don't have time to come to the hospital, you know, and these are the barriers of management, really, if you think of managing children with obesity. Getting the children to stay in our obesity clinic is a challenge. And this is the world in which the children live in, right? They come and then they go back to all these influences, and it's difficult for a child with the environmental influences to actually stay on the narrow path, really, you know. And so management will really require not only what we just mentioned, but much more like public health and environmental sort of measures to tackle that. I end maybe with something like this, the burden of childhood obesity, because, you know, if we don't do a good job, this is going to continue on to adulthood. This is data from Harvard showing that really 3 out of 4 2-year-olds, all right, who are obese will still have this obesity at the age of 35. And this is prediction really of the 2-year-olds. And at age 2, they were at 9%. And at 59% of them will be obese at the age 35. And I put the dollars there as a sense there, really, because if we think about it, the financial implications of this will be momentous. So really, I end with this. Eric Finkelstein is a researcher from Duke, and he says that for the same reason we don't let kids drink or smoke and force them to go to school, we should also do our best to keep them as a healthy weight as possible. So really, thank you very much. And this is an effort we are doing, Jom Sehat here. So we're starting doing online obesity clinics because it's difficult for parents to come. You know, they can't come. So we do online ones to do fun activities so that we hopefully can help them. You know. So thank you very much.
Thank you very much for that, Very interesting sharing, Dr. Nalini. Any questions from members on the Zoom right now? I thought I saw Prof Ismail tangan naik tadi, dah turun balik ke Prof? And on Facebook, let me just check. All right, I'll kick it off, Nalini. You've covered the psychological aspects and you've touched upon the environmental, our living environment, which influences our behavior. So in a way, it is psychological. So what would you say, in your experience again? I mean, for these kind of sessions, it's always I would like to take the opportunity always to find out your perspective really when it comes to fellow healthcare providers. So the reason I'm asking fellow healthcare providers is because most of the audience will be healthcare workers, right? They're not going to be general public, well, not at least on this webinar. What would be their commonest misperceptions when it comes to managing obesity in children and in adolescents? And what would your general guidance be to address those kind of misperceptions?
I think that the biggest challenge, I think, is that to think that's not a problem, really. Right, that the child will grow out of it, because you see a lot of us see the children in your growth and development clinic, or your asthma clinic, asthma clinic. A lot of asthmatics are obese, and so because you see the child in a different setting, you don't realize the child is obese or overweight, and then you think, oh, maybe he will, grow out of it, and then you realize with time it doesn't happen, that way, So I think the perception that that is not really a problem. And also the severity, that means sometimes we laugh with the mom and dad and say, oh yeah lah, they will be okay, that kind of thing, So we condone the not the complacency, maybe I would say, of the mom and dad, not to mean that you need to be very vigilant, but it's just that when you do that, the mom and dad feeds off you too, So I feel that may be the barrier to that, And so what would I say? I don't say everybody refer, no, I don't mean that, But what I do mean is that maybe you explore, and that's why you have that stage 1, in that assessment thing, you explore things, simple things which you can help, you've got that diet, exercise, screen time, sleep, and physical exercise. Right, so you just do those few things and just see which one can you slowly start to change. I only change one thing each time, So I just, like today, I saw a boy. I said, okay, let's just do one thing. Okay, we are not going to drink gassy drinks. That's it. Okay, just one of these small things, because behavior will slowly change, and children will feel better if they can achieve small goals rather than giving them this because children can't take complicated things. They can take one singular sort of goal performance. So I think that's what everyone could do. Then you wouldn't have this 100 kilo referred to me at 10-year-old, that's what I mean, really, we're starting to see more of them. The other thing I would stress is also the less than 5 years, because we're seeing a lot more obesity in that group, because complementary feeding sometimes is not introduced in the right way, and also the excess screen time now, and children don't go out and play, So that group actually is a group of concern, So I think when we do see our patients in our clinic, KKs, explore these simple things, and you'll be surprised, a lot of parents don't really know simple things like, oh, they should sleep at this 8 o'clock or 9 o'clock, or they shouldn't use so much screen time, and just by reiterating that, I think that would be great. Yeah.
Sorry, following up on that earlier, your response, do you feel that parental knowledge, parental skills are still poor from the patients that you see?
I think it's parenting in this age is difficult. It's different, We grew up in a different age, and this age is very different because of media, right? And because of the fact that children these days are so much more exposed. So yes, I don't want to say that I'm a great parent either, but I think that we do need parental support, in simple things like even food choices, or even breakfast. You know that most kids don't eat breakfast. This is like a pet peeve of mine. So even those kind of simple things, that they might need some assistance, really. And just it's more help. You can talk as a friend to the parent. Yeah.
Rukia.
Thank you very much. Dr. Feisul, you can't see me because I'm against the light. I've got the background dark. Okay, Dr. Feisul, I just want to put a question to Dr. Nalini. Dr. Nalini, in one of your slides, yeah, you have actually indicated the link between obesity and sleep deprivation. Now, I'm not too sure whether you've got data amongst your obese children that you are managing. How is their sleep duration like, you know? I'm worried, Dr. Feisul, because if you look at the number of hours of sleep that's recommended here for children, our adolescents especially, yeah, 8 to 10 hours and 3 to 5, 10 to 13 hours. I'm not too sure whether they actually get that duration of sleep. And if they do, whether it's interrupted sleep or not, because we can see that our younger children, our children are now spending a lot of time on the screen, you know. So if it does, if the link is evidence-based, yeah, so maybe, Dr. Feisul, in our dietary guidelines or in our whatever health guidelines we have, we should put some recommendations of sleep hours, yeah. Maybe Prof. Ismail, being the chairperson of the Malaysian dietary guidelines, yeah, we should include that in our dietary guidelines, the number of our sleeps. Obviously, I don't get that number of hours of sleep. I mean, at the age of 60 plus. You know, so it is important. Maybe this is a factor that we are also overlooking, you know. I mean, we don't pay much attention to. Dr. Nalini, maybe you have some data to indicate that proportion of your students, of your patients that are actually having obesity problem and how many hours of sleep they have.
Yeah, yeah. Thanks for that question. That's really good. I haven't done a study in my patients per se. I mean, like objectively as a study, but real world data will tell me that most of them do not get enough sleep because of the devices, really, because most of them are on YouTube or and I think that part of it is linked to COVID also, because they have had a lot of disruption with schooling and all that, and so they've been left to their own. It's very common for parents to tell me that they would go to sleep at 9 to 10 o'clock because they're so tired, they're working, you know, but the kids will be on their devices until 2, 3 a.m. And then if they don't, and because, you know, now PDPR and all that, you can just do the work online, you see, so you don't have to wake up at 6, 7 o'clock, you know, anymore, you know. So that sleep pattern has crept up really among our children, even younger children, you know. So, you know, when you look at that guidelines, you know, I also look at it as thinking, oh dear, I don't think most of them get that, you know, but I think that the amount of sleep the children are getting is very disrupted also, because they would sleep at 2 and then wake up maybe at 7, 8 and then sleep in the afternoon again. So they don't get a night sleep, you know. Yeah. So, but you're right. It is a good study to look at the sleep of Malaysian children. I don't know. Yeah, I know. Yeah.
Thank you for that. Thank you for that.
Feisul.
Yes, Prof.
Sorry, because Rukia mentioned my name just now. Yeah, we are actually
respond to that.
we are actually updating our MDG for children and adolescents, and the figure that you showed just now for sleep time, that's what is going to appear in our guidelines. But whether children do have enough sleep, that's another matter, but that will be recommended as others are recommending the same time frame, right, for children and adolescents. So it is being updated, yes, to answer Rokia's question lah. Yeah.
Thank you. So before I wrap up, finish off this session, Nalini, thank you. The question from Puan Rokia about the sleep, that even creeps into the adult in terms of rates of NCDs as well. So, but I've not known, I don't think anyone in Malaysia themselves have looked at it specifically. Okay, so for the listeners out there, you know, the relationship between sleep and NCDs in general is something that more and more people talking about, and certainly something worthwhile exploring as part, you know, as these non-traditional risk factors for NCDs. So thank you very much, Nalini. I'm going to let you go. Moving, keeping well to time. Thank you very much to all speakers, and I'm going to introduce the next speaker, who is Dr. Gafoor Mubarak, who is a general, minimally invasive surgery and bariatric metabolic surgery consultant working in Island Hospital, Pulau Pinang. So as his job implies, job title implies his interests are in MIS, minimally invasive surgery, and also in bariatric surgery. And we have the pleasure of listening to him talking about patients and procedures selected for bariatric surgery, current and future trends. And I'm sure there'll be many questions afterwards, Dr. Gafoor, so I'll pass the floor to you.
Great. Thank you so much, Dr. Feisul. Thank you so much, Dr. Nalini and Dr. Firdaus. I really enjoyed listening to your talks. And thank you, Prof. Ismail and Masu, for inviting me for this talk and giving bariatric surgery an input. So let me just share my screen quickly. Okay, great. So as you know, bariatric surgery is now one of the more popular arms of surgery that is being done, particularly in private practice. You can see that the trend in private practice is a lot of new surgeons are picking it up, because definitely the volume is there. Technology is changing very fast, and also the trends related to bariatric surgery now, the availability of training for us to attain the skills is easier as compared to before. And also patients' fear towards being potong and dibedah is actually much more controlled now as compared to before. So just a brief layout on what I plan to talk about. So to some of you who are not very familiar to who I am, basically I am very much a Malaysian. Many people think that I'm not from Malaysia, but actually I'm very much born and bred everywhere here. And only recently, about 1.5 years ago, I left the government service to be in the private sector. And besides bariatric surgery, I still do my repertoire of general surgery. But the pattern of patients that we do now for obesity is basically disproportionate. When I began my practice, it was close to 10% or maybe even 5% weight loss, even though I finished my fellowship, and about 95% bariatric. But now the trend has reversed, where I'm doing about 95% patients bariatric and only about 5% patients in terms of general surgery. And general surgery patients, in fact, come to us who basically have got a lot of obesity related problems with their general surgery. For example, they are obese and they have a gallstone, or they are obese, they have a hernia, or they are obese and they have a colorectal cancer or a stomach cancer. So the surgeons that they go and see are not very comfortable in managing them, and they feel that a bariatric surgeon would be better served to actually treat them and also help them in getting their problems sorted. So as many of us now have come to realize, the problem with obesity in Malaysia still remains the same. It still remains to be a cosmetic problem. There is very little initiative, especially from the government, in terms of bariatric surgery as compared to our neighboring countries now. We find that Singapore has got government aids. Thailand also has now jumped into the bandwagon, where government offers assistance to patients who are keen for weight loss. And our other problem is we have got very good food all day, and most of our food is very small in quantity but very high in calories. And a good example that I would like to bring out, which is very popular in Penang where I work, is cendol, and also our mi goreng or char kway teow, where it is the quantity is small. Lepas makan you rasa lapar lagi, tapi the amount of calories you have is very, very big. As compared to traditional foods in other countries like Thailand, for example, pad thai, it is a salad that you can eat. The quantity is small, calories not so much, but it is a signature dish from there. So our signature dishes somehow or other have got very high calories, and this, I think, contributes largely to a lot of our problems related to obesity in this country. What has happened over the past 2 years, many of us concur, as I have listened to all the presentations, is that the obesity issue has become more prominent. Patients who stay back at home lead a more sedentary lifestyle, and therefore they creep up in their weight without noticing. snacking has become very common, and we find that our referrals to our clinics have become very much increased, especially to the end of MCO2 and MCO3, which happened between August, September, and November of last year, right? So we are still the champions in ASEAN, where we are the most obese nation, a title that we would be happy to discuss. Now, in a bariatric point of view, it is a bit challenging to treat our patients in the early 2010s, 2011, 2012, because the BMI cutoff point for Asian patients are far less as compared to our Western counterparts. And many a times when we were being referred patients with higher BMI for bariatric surgery. And many a times when we intervene at that particular juncture of BMI, our outcome is not as good as if we intervene a bit earlier. So this has changed now, where we have come to realize that class 1, class 2, class 3 obesity has got a lesser number for our Asian patients as compared to our Western counterparts. And as you know, obesity has got a host of a lot of other problems related to obesity. And our primary referral now, which I find, which is similar to other bariatric surgeons, is knee pain and back pain. This is the number one main reason why they come to us. Diabetes, of course, is a given. They definitely don't like to take more than one or any injectables, and they come to us for advice on any ways that they can reduce their weight and also reduce the amount of medication, or if they're lucky, be off medication altogether. And the other big group now that has cropped up is patients with primary infertility. So patients that get married at a young age or at any age, and then they find that they cannot have any techniques to conceive, including IVF or IOI or any of these, come to see us for weight loss before going for other techniques actually. So these are the three biggest groups. So the main referral comes from our orthopedic counterparts. The second biggest referral comes actually from our gynae counterparts. And only the third biggest referral comes from my endocrinologist at Island Hospital. And this is a trend that I see is very similar in other, centers as well. The reason is very simple. I think the orthopedic surgeon doesn't think too much. He just sees a patient with knee pain, overweight, and he refers them. But I think an endocrinologist will go through the protocols properly before seeing that this patient is suitable, and then refer the patient subsequently for bariatric surgery. So how do we overcome most of these problems is we, of course, advise patients, like Dr. Nalini rightfully said, exercises, reduce screen time, exercises, and also then we move on to medications. But most of the patients that have come for bariatric surgery are those that have tried these for 4 to 6 months and subsequently decide that it doesn't work, and they come to us for treatment. So what happened was we all sat down about 5-6 years ago, and I think some of you in the panel were involved in our discussion. It was called a BMW Bariatric Metabolic Working Group. And then we began formulating our indications for bariatric surgery from our Malaysian context. We also invited some international panel, Professor C.K. Huang from Taiwan, Kasama Kazunori from Japan, and also Professor Wei Jie Lee from Taiwan, and Professor Sutep from Thailand, to help us to actually formulate a protocol that is suitable for our population. And we have had these meetings many, many times, and it has been renamed also. The problem that occurs is the chairman will always be someone who is the head of bariatric or upper GI, and then subsequently this person would be replaced by somebody else, as this person either has gone to private or the chair of that particular field has changed. So there is a delay always in publishing these protocols because there was so limited number of us doing it, and the change happened so rapidly. We managed to publish this in the Malaysian Medical Journal last year, and now this is the protocol that we follow for bariatric surgery at this particular moment. Basically, patients that have got BMI of 37.5 and above, who actually, whether or not they have any metabolic syndrome or any other diseases related to obesity, automatically qualify. And this forms the biggest bulk of our patients at the moment. The second group is patients with BMI of 32.5 with any related comorbidity, which includes diabetes, subfertility, or hypertension. Now, what about patients that have got low BMI with or without comorbidities? It is generally our practice not to actually perform these procedures for patients with BMI below 32.5. However, under special circumstances, we do perform them, especially if these patients are battling with psychological issues related to their weight for a long time, and they truly understand the nature of what they are about to embark in. And we have a very thorough assessment together with our physician and our in-house psychologist to determine whether or not this patient actually qualifies. We have restricted the age to those who are less than 65 years old. This doesn't mean that we don't offer bariatric surgery to children. We do, but again, it is in relation to a close relationship that we have with our pediatrician colleagues. Personally, I've done 4 cases, which again have been referred by the pediatrician, and then subsequently we work with their parents and with a clinical psychologist to make sure that this indication basically is proper. Of course, patients with mental impairment, which are also again uncontrolled, is a contraindication for bariatric surgery. Active neoplastic diseases, pregnancy, immobility, and the other big group that seems to be cropping up are patients with substance abuse. We find that some patients are coming to us who have got substance abuse and who are keen for bariatric surgery, and based on our criteria, we have to turn them down because we find that the self-control in these patients is not that good. And people tend to misunderstand that bariatric surgery tends to be a fix-all kind of a problem, but it only works if the patient complies to our dietary regime. So we have a bariatric team which consists of a surgeon, psychiatrist, coordinator, dietitian, and endocrinologist. And I think if we are to embark on this, we need a team. We have several techniques that we are using now. The balloon now has cropped up to be a very popular way of losing weight. I put in my 56th balloon last week, and over a span of 1 year, which is actually a very, I would think it is quite a high number, because looking at the population and the price of the balloon, many patients seem to be interested because it doesn't require any GA. It is a swallowable balloon and it is temporary. So I feel that this is the aspect of treatment that is cropping up now. Of course, our mainstream of treatment and our most popular product remains to be the sleeve gastrectomy. So the sleeve gastrectomy basically is one of the most durable and one of the most simplest operation that we perform for bariatric surgery. It requires you to actually clear off the greater omentum and stapling off about 70% of the stomach. And it is not a very technically demanding surgery. However, the complications related to bariatric surgery can be very demanding, right? So these are a few of our patients. This is a patient that we had for balloon, which lost about 15 kilos before the balloon. And this is a patient that we had very recently who was 148 kilos and who came and saw me at about 72 kilos after 8 months. His wife subsequently also performed the procedure with me after he lost so much of weight, and she also lost about 42 kilos. Both patients were diabetics, and both had complete remission from diabetes at about 18 months after follow-up. So the trend is now we are seeing about more than a bariatric surgeon who focuses on bariatric can do about maybe about 110 to 120 cases per year. Of course, there are some centers doing more, 500, 600 cases even per year, some centers in KL. But this is, from our experience, we are a very new center, and despite being new, we can still accomplish that number. This shows that actually the awareness regarding bariatric surgery among our population is increasing quite rapidly. And these guidelines are very important because if we don't have it, it exposes a lot of room for abuse at times. So we should be careful how these guidelines come out, because if these guidelines are not there, then people will interpret any overweight patients to be suitable for bariatric surgery. And this also opens up another can of worms, because at the moment now patients are able to make withdrawals from their EPF accounts to pay for bariatric bills. So there is a financial aspect to it as compared to a social aspect to it as well. So while we are trying to overcome this problem of reading ourselves of this label of every 2 patients, 1 of them is obese in Malaysia, we have to be careful that we are doing it for the right reasons. And we have to be careful that we are doing it for the right indications as well. And so I feel that these guidelines that we have put up, especially that we have published last year, should be followed very carefully when we want to, manage bariatric patients. Let me just see if the video plays. I'm not sure if it does. If not, I'll just play it in the end. Give me a minute. Okay, let's move on. Then I'll play the video in the end. All right. So besides the other indications that I gave, there is one that I would like to highlight here, which is for pediatric patients. So in special circumstances, you can actually perform bariatric surgery outside the criteria that we have put. However, it has to be done in close relationship with other doctors, physicians, pediatricians, and orthopedic surgeons. And this is again what we have put into our criteria as well. Okay, so we need to have a team behind the bariatric services. The team, of course, can be led by the surgeon or the physician. The physician can be a physician that is basically an endocrinologist, or a physician that has got an interest in obesity, diabetes, and metabolic disorder. In my hospital, the physician who is involved is actually an endocrinologist. The other key element is the dietitian. I cannot stress how important this dietitian's role is. The earlier the dietitian gets on board, and the earlier the patient understands the regime that they have to follow, the calories they have to stick to, and the culture they have to develop before and after the surgery, the easier and the better the outcome is actually for the patient. Clinical psychologist and psychiatrism plays actually the next biggest role. And in our hospital and in my practice, the standard round that they do, I call it, is definitely to the physician, which is either the endocrinologist, the dietitian, the clinical psychologist, and the physiotherapist. More than ever, the psychologist is not only to get the patient in the right mindset, but also to make sure the patient is doing it for the right reasons. We find that a lot of patients are doing it because they are being influenced by partners or being influenced by parents or spouses. So this is some sort of a no-no for bariatric surgery, because we need the patient to understand what they are doing, because there are consequences to them not following the regime. For example, if you have a patient that is suffering from depression, or if a patient suffers from bipolar disorders, I think one of the bigger groups that come to us is patients suffering mainly from bipolar disorders. And these patients are not stable for surgery and not assessed properly. Many times they hide their psychological or their psychiatric symptoms when they come to us, and during assessment, because they visited many psychologists before, they're very good in masking these symptoms. Because as you can look in Facebook and in Instagram and Telegram, there are many bariatric groups, that teach these patients how to act when they come and see us. So when they come and see us, they know, doktor, saya mau buat sleeve. Doktor jangan potong banyak sangat. Doktor bahagian bawah potong sikit, bahagian atas potong banyak. So they kind of have all this information already before they come and see us. Doktor, saya sebenarnya makan ubat darah gastrik saja, tapi bukan selalu. But actually, when you dig deep into their history, you find that they've got severe gastritis. They've been admitted for gastritis. So all this information that they get on Facebook, especially through Facebook groups, through telegrams, assist them to actually sort of kind of deceive us sometimes when they come and see us. And it's very important that we have these checkpoints to make sure that we don't miss this type of patients when they come and see us. Just to give you a perspective, one Facebook group in Malaysia has got 72,000 members, and it is dedicated only for obesity and bariatric. And it is managed by a weight loss surgeon. It is started by them and it has grown to become about 70,000, 75,000 now at the moment. And you can imagine the reach that this group has, because those 75,000 are able to disperse information within their circles to their friends, to their family, and that number quickly extrapolates to become 100, 150,000, 200,000 in one go. So it's very important that you have these top measures and these checks to make sure that you are not off guard. So we have a few procedures at the moment. Based on our criteria, we only have the gastric band, the sleeve gastrectomy, the bypass, and the BPD switch. This is because when we embarked on the protocol in 2011, these were the only established procedures that were available. But now we have got many, many more. We've got single anastomosis duodenal switches. We also have got the proximal diversions and the distal diversions, the foregut diversions and the hindgut diversions, which are actually more, I would say, elegant procedures as compared to what we used to have before. So I think this again will require another round of us sitting down together and coming up with it. And when you select these patients, a very important element is they must have had some attempts at weight reduction at least 6 months. And this element of the Q&A must be very careful. The reason is because of motivation. And these patients must be willing to come for follow-ups. And they have to comply to our dietary regimes after the procedure. So again, contraindications that I've mentioned, we're just putting it out here again. And actually, at the moment now, we are doing a lot of balloons. And this balloon, which I put up here, is one of the more popular brands, which is the swallowable balloon. My video doesn't play, but I'll try to get it at the end of the presentation. So what did I miss actually, or what do I think is missed from the presentations or the protocol? Number one is medications. We did not include medications into our protocol because we find that more and more patients now are coming to medications as an adjunct or as a means of losing weight after the procedure when they have plateaued. So many of us are using existing studies, and of course the liraglutides are the ones that are the most popular. I think it is driven a lot by the company itself because there are other available drugs that are equally, if not more effective, that we can use. Endoscopic procedures are quickly cropping up now. We are doing a lot of sleeve-based, sleeve endoscopically as well. And newer surgical techniques are getting into play. And like Dr. Nalini explained before, there is a role for bariatric surgery in children. Balloons are getting more easily to be implanted, where patients just come to the office in the morning, swallow, and go back to work after that. And also we need to actually establish criteria to determine what is actually a center of excellence for bariatric and metabolic surgery. This is again missing from the protocol. So the future, I think, will be newer endoscopic techniques. So newer endoscopic techniques, again, my video is not coming up. Let me just try again. Yeah, and also, patients that come to us basically after surgery, especially after bypass, as you can see here, this patient has had a bypass, but the lubang that has been created for the bypass has expanded over time. So this patient has plateaued and the weight loss is not so good. So basically we can do an endoscopic procedure to ablate all around this particular lubang to actually make the patient lose more weight. So the future, I think there are better and better medications coming up. And I think with time, we will only see that these medications will crop up and maybe the role of bariatric surgeons will become much less in the time to come. All right. So that's it. What do you call it? For my presentation, I think I would like to invite if there are any questions that are available.
Thank you very much for that, Dr. Gafoor. Thank you very much for firstly covering the technicalities side of it. of surgery, bariatric surgery, and also actually what's more interesting to me, your personal perspective about how patients who see you are engaging with you, and what, and the tricks they have, they up their sleeve compared to the tricks you have up your sleeve. So they have their tricks as well. Okay, we are at 4 p.m. I think if everybody agrees, we'll just pull this a few more minutes if there are any questions from members either on Facebook or on this Zoom call. Right, I don't see anything. Actually, I've got some questions before you started, but actually your talk covered it. So I'm pleased to hear what you have to say. Sorry, Prof. Ismail.
Hi, Dr. Gafoor. Thanks
Hi.
for you actually talk about the procedures, but you
Yes.
haven't given us any results, of your studies or
Right.
of the patients. I would have loved to see some of the
Right.
success.
I think I need more time lah, Prof, for that.
Yeah, tapi kena masukkan lah juga. Jangan promote only the.
I need more time.
Well, you did very well, but this is
Yeah.
a question that many of us have been, at least we heard lah. Are you guys putting the endocrinologists out of business?
Definitely.
You have to tell us
Definitely.
your frank opinion.
Yeah.
Because everyone thought that, or at least they say after surgery you get rid of a lot of all your comorbidities simply disappear.
Right.
Is that true, or how? What would you say about, or your comments on it?
Right, definitely not, Prof. Ismail. You see, this thinking that bariatric is a magic bullet for metabolic disease. It's actually it is, I think, market driven. It is something that we use to sell, but the reality of it is very simple. Once you do bariatric surgery, you see the patient for 6 months, patient won't have diabetes. See the patient at 1 year, patient won't have diabetes. You see the patient at 2 years, no diabetes. At 3 years, something crops up, and
okay.
And most likely, if you, and the selection of the procedures that you choose for these patients are very important. Many a times we find that in Malaysia, the problem is we are doing too many sleeves. That means we are trying to solve a metabolic problem by doing a restrictive operation, which doesn't work. It may work in about a small percentage or some higher percentage, but ultimately you will have patients coming back with need of medications for diabetes in the long term. The proper treatment for this is, of course, a bypass procedure, but a bypass procedure requires that much additional skill and training on the surgeon's part. And the follow-up with regards to the bypass is not as simple as the sleeve. And many a times, the bariatric surgeon will definitely need the endocrinologist's help to follow up these patients when he does a bypass procedure. So to answer your question, I definitely think that there is a very bright future for all the endocrinologists.
Yeah, that's...
And I feel that the way to move forward is definitely to complement each other.
Okay. So it's enough on the table for everyone.
Yeah, the pie is big enough, so everyone can actually enjoy.
Yes, thanks.
No problem.
Thank you.
Most welcome.
Sorry. All right. Thank you for that, Gafoor.
Thank you so much.
I just want another question. This is very specific. Talking about complication from sleeve gastrectomy. This is, I think, hiatal hernia.
Right. Okay.
Is there any way to prevent?
Okay. So when you do a sleeve gastrectomy, the general contraindication is if you have severe GERD, you should not do a sleeve gastrectomy. But what is happening in Malaysia is we find that this budaya of gastric is very strong, especially among our patients. Actually, if you look at the demography that we are doing, we have papers in the study I didn't highlight it here, but easily about 75–80%, in fact more, are our Malay population patients. And many of them at one particular juncture of time in their lives have had some sakit gastric. They perceive gastric as everything, kita ada angin, bloatedness, apa-apa pun gastric juga. It's all into one category. That is why when we properly do a scoring system for them, such as a DMISTER score or things like that, we should clearly identify who are the ones who are having severe GERD. And the ones having severe GERD should not be subjected to sleeve gastrectomy. If the patient has got a hiatal hernia, obviously, if the hiatal hernia is not repaired during the operation or the sleeve gastrectomy, this has got potential to create more problems for the patient. Symptoms may become worse, or there may be migration of abdominal contents into the thoracic cavity because you have got this hole. So it becomes a very difficult problem to manage if it happens. But routinely now in my practice, and I think in many practices, we repair the hiatal hernia when we basically, if there is a hole, we patch it up and then only we do the sleeve. And most of the Asian sleeves are very tight. They use a very small bougie. So this is why the propensity to develop GERD-related symptoms after sleeve in Asian populations is more, because the surgeon makes it very tight.
Thank you. I think from just hearing what you say, the skill, competency of the surgeon is very important in terms of understanding the patient and understanding the correct procedure. That was why I didn't really asking about effectiveness. I know the data, but I think if you choose wrong, or if your competency is is not to that level, then you will get poor results.
Sir, Feisul, I cannot understand how you can do bariatric. For example, if you're doing a list of regular cancers or regular general surgery, and bariatric becomes, something extra that you do, because it is definitely a very, I would say, a very technical procedure that needs to be tailored for every patient.
All right. Thank you very much. We'll let you go, Dr. Gafoor. Thank you very much for that sharing. So just to wrap up, I would like to, on behalf of Manso, to thank all the speakers, Dr. Nalini, Prof. Dr. Norlaila, Prof. Dr. Firdaus, and Dr. Gafoor for their time and for their sharing with us. And I certainly have benefited from this. So thank you, Manso, for inviting me to chair this session. And before I end this, I would like to pass to Jasmine. I see Prof. Gita there with the video on. Okay, thank you very much.
Thank you, Dr. Feisul.
Bye-bye.
Thank you, all speakers. So on behalf of MASO, we would like to thank Dr. Feisul and all our distinguished speakers on their sharing session today. We would also like to thank all our participants on Zoom and also Facebook, MASO and Nutritionist KKM for tuning in to today's webinar. Before we end, I would like to invite Associate Prof. Dr. Gita Apana, the current President of MASO, for the closing of Obesity Week Malaysia. Dr. Gita.
Thank you, Dr. Jasmine. Ladies and gentlemen, it's a great pleasure for me to say a few words at the end of this Obesity Week Malaysia 2022 event. As you probably know by now, today's webinar session is our last obesity prevention effort in this Obesity Week Malaysia 2022, but it is not last as such in our journey to prevent or reduce the prevalence of obesity in our country. There's more to be done, and we all have a role to play to ensure success on obesity can be achieved with the right approach. It is hoped that in this Obesity Week Malaysia 2022, we have increased more awareness and understanding on obesity risk and their prevention strategies. I'm happy to share that our physical events in Sunway Velocity Mall from 25th up to 27th for the last weekend were very successful, with a very good response from local medias, community, and policymakers. Apart from that, our virtual events were also very successful, with encouraging social media metrics. Our webinar sessions were watched by more than 3,000 people so far. This success wouldn't be accomplished without my wonderful and hardworking team both the MASO concerned members, as well as those from the Nutrition Division, Ministry of Health. Thank you so much for your effort, time, and sacrifices. Ladies and gentlemen, I look forward to continuing this Obesity Week program in the coming years with better programs, better activities to suit the burden or the issue of obesity in the coming years. I trust that all of you will continue to support us with that. Thank you very much. Dr. Jasmine, over to you.
Thank you, Dr. Gita. So this marks the end of our week-long Obesity Week Malaysia 2022, which was jointly organized by MASO and also the Nutrition Division, Ministry of Health Malaysia. We would like to thank everyone for their contribution and also support to make this event a great success. Please remember to fill up the attendance form for your attendance, for your certificate, and also to all local medical doctors, please include your MMC number for manual CPD entry. Thank you and have a great day.
So well done, Dr. Gita.
Thank you, Prof.
Yes.
Thank you,
well,
Prof.
till next year, we start.
Till next year. We do it much more earlier.
I'm not too sure how many. Yeah, we should keep tab on how many following actually the sessions. And
today
come
was
up with a
highest
report.
200 over.
That's very good. Yeah.
Yep. All right, thank you, team, and concerned members. Will meet again for postmortem soon.
Everyone.